So, Chris, can you just give us a brief sort of introduction as to what you do here?
Yeah.
What your role is?
My name's Chris Walker. I am a senior physiotherapist, amputee rehab. So we work here mainly as an outpatient service, trying to rehab patients that have had amputations, mainly lower limb, can be at any level, but also we do see upper limb patients. And then we link in with the inpatient therapists to try and help them from the initial amputation through to outpatients and then out into the community. We also see some of the amputees that come through as outpatients but for other conditions. So it's say they might come through with low back pain, they might come through with contralateral knee pain and things like that as well. So we kind of try and see those patients all encompassing.
Okay.
Cool. Are there any differences between treating a lower back pain patient in a fully abled patient or an amputee patient? That makes sense. We're going to type them in. Basically, are there any differences between treating a fully able person and an amputee for low back pain?
Yeah, I mean, I'd say there are obvious differences in terms of potentially reasoning why the person's got low back pain, and so obviously potentially it could be that it's to do with adaptation, it's to do with malalignment, it's to do with repetition of certain movements that's what kind of caused it. So that's one of the things that's maybe quite difficult in terms of thinking about treatments of that person, because you're never going to be able to fully avoid doing the activity that they're doing if they're walking around. So it's a lot of it is kind of management and trying to make sure that the patient's educated. If you know that what you want to be treating, whether it's muscular, whether it's kind of joints or anything like that, then you can do obviously some specific treatment techniques, the same as you would do other patients. A lot of the patients can still get into prone, can still get into side lying, can still get into supine. However, moving through those positions might be a little bit more difficult.
Yeah.
So it's very much kind of trying to target, pinpoint maybe the cause, and again it depends on how long sometimes they've been an amputee. They may have had low back pain prior to being an amputee, so actually it might be a chronic kind of problem that actually just exacerbated by what they're doing.
Alright, so in sort of respect to exercise programs, we like deconditioning and postural changes, obviously, post-surgery.
Yeah.
You just tell us a little bit about the exercises that you would
So in terms of generally the patients would have their own exercise program from coming out after being an inpatient. The national guidelines for amputees give a certain amount of exercises called peer pack exercises.
Okay.
However, then we do generalised kind of cardio exercises, upper limb exercises, and then obviously if the patient is presenting with kind of low back pain and kind of problems that are irritating from that, we would maybe give them exercises specific to that. But I would err on the side of functional exercises rather than giving any kind of specific kind of McKenzie exercises or anything like that that's kind of specific to low back pain, because at the end of the day, whatever exercise they do needs to be functional for the patient, and if they're using a prosthetic leg, then they need to be able to adapt between their movement function with the prosthesis or without the prosthesis as well. So there's no set program that I would give them. A lot of it is very functional. It's very much trying to make sure that they're doing all the generalised stuff to get themselves nice and conditioned. Postural stuff is key, especially with people in wheelchairs quite a lot.
Yeah.
Trying to make sure that they're aware of that. Core stability exercises, very much integrated into their early rehab, and then trying to get them to continue that throughout as well when they're up and walking. And then obviously looking at postural alignment when they're walking as well. Depending on the walking aids, that can obviously change people's position, also can have an effect on people's back pain depending on how far they're walking and what kind of walking aids they're using as well. So I guess we give them specific exercises to be doing at home, but then also kind of try and look at them generalised in terms of when they're up and standing, the different postural sets sort of thing as well.
Okay. We've read that scoliosis is relatively common in amputees. From a conservative perspective, how would you go about treating that?
Like bracing.
So like bracing exercise,
it's difficult. We do link in. I mean, obviously, scoliosis and adaptation like that probably occurs after quite a long period after being an amputee, and depending on that level. Obviously, the higher up you get in terms of amputation, obviously the more likely that is to occur. For our transtibial patients, I don't see that it tends to be so much of a problem. For transfemoral ones, it more so is, and for the few kind of hip disarticulation patients that we see, it's quite evident that's going to be a big issue because of the mere fact of the muscles that you're using on your back are completely different compared to if you're trying to use a prosthesis. So we link in, we've got orthotics team here that we link in with that give that do braces and that help us to try and fit those braces alongside the prosthesis if needed. We'd also obviously give kind of like an exercise program as best we can, but also look at the function of the person as to what they're trying to do on a day-to-day and how they're doing it, and whether the person's trying to get from A to B or just do things because that's what they want to do, or whether they're doing it quality or quantity of the exercise, and try and educate, because actually the patient's education of what they're doing, why they're doing it, and what they're causing the body to do is probably the key factor to actually whether that's the scoliosis is going to either improve or whether the muscle function is going to improve, and how they're going to be kind of continuing on, and how long they're going to be a prosthetic user for. So it's kind of like taking a bit of an MDT approach, but hopefully they don't get to that stage of where they've got that adaptation occurring, but it just depends how frequently we see them and things like that as well.
Getting on to sort of yellow flags, obviously this patient's actually quite a lot of yellow flags associated prior and post-surgery.
Yeah.
Tell us a little bit about what's common, how it might affect treatment, how it affects patient goals and things like that.
Yeah, obviously it depends on what's led the person to get to the surgery. There's maybe key differences between some of the traumatic patients and then some of the more vascular patients and more elderly that have had ongoing problems prior to the amputation itself. I guess key things are social factors, support and everything like that in terms of what they've got in place to help them progress, and then also in terms of their goals and commitments that they've got that want to move on to, so work commitments and family commitments, and just key things. We're always on the lookout for yellow flags, but I would say the population of patients that we have in general, the ones that kind of come through here for prosthetic training, are very keen to get up and get going and get back, and those are the sort of patients that they're not the ones that kind of rest on the laurels, that don't want to progress. It's in their benefit because of the fact that they want to be able to access their house, different areas of the house that they can't normally access because of the wheelchair, because the doors aren't wide enough to get around, so they don't want to be living in one room, they want to be walking around the house. And so I think that has actually, have that background awareness of yellow flags, but actually it's just kind of, I think a lot of the patient group actually are very proactive in terms of trying to progress on. The ones that aren't, then we would obviously try and put support structures in place in terms of linking in with either services, linking in with the occupational therapists to try and help them through the different factors for adaptations and the home environments to make things easier. And also we've got cognitive behavioural therapists here as well that we can kind of link in with as well, that if we know that people are really struggling, that can help them bring them through those situations as well.
How much you know about CBT?
Yeah, I mean this patient group in terms of CBT is kind of key. We have a living well with amputation course that we run here. So alongside kind of we've done 3 courses so far, about 6 weeks program that we've linked in with our psychologists that kind of who do the CBT program to help on a basic CBT approach, however, just to try and educate them a little bit more. So that goes hand in hand with what we do in terms of the primary patients to progress them through their first year. Obviously the patients that aren't progressing well, and we feel there's a lot of factors to whether it's just recognising the fact that they've had an amputation, acknowledging their stump, acknowledging what they can and can't do. CBT is quite it seems to quite help in terms of open up the patients to talking that little bit more. And kind of recognising that potentially some of their thoughts that they've got about what's happened or why it's happened, what's led to that point where they are, actually there are different reasons that can help them through that, and I think CBT seems to have helped quite a lot of the patients.
Do you think it directly influences back pain?
In terms of the back pain, I think it has a good effect. If the patients have got the back pain, I think it might help them reason as to why, if they're not kind of if they're not able to process the general kind of reasons. But I think in general the CBT, if the patients recognise why if we're talking about back pain and amputees, if they recognise why they've had an amputation, I think that will probably help them recognise why they're getting that back pain sort of thing.
And do you do any specific treatments such as like using TENS or acupuncture or anything like that on your back pain patients?
Yeah, so we've got, I've just actually started using acupuncture, so I've had a few patients that have tried it on and tried using it on. TENS we've used quite a lot, and that has varying effects, obviously, in terms of the patient and in terms of the area we tend to use it on. The patients that I've kind of used acupuncture on, it has been quite beneficial. It's had quite more of a global relief for the patients rather than more of a specific kind of specific point. But actually, we never couple just TENS or acupuncture on its own. Generally, we do that in conjunction with an exercise program and also the normal rehab that they're doing as well.
Good stuff. And just finally, sort of recommendations in terms of day-to-day that you give to your patients, really, to avoid sort of comorbidities.
Yeah, so I'd say just in terms of the same as we'd say for any patients, really, not staying in one position for too long, trying to avoid, obviously, sitting in the wheelchair is the main thing for too long. Yes, they're going to be in it for a long time, but maybe even if you just transfer from wheelchair to a chair, trying to do regular exercise, thinking about posture when they're doing their exercises, and then if they're at a stage where they're prosthetic wearing, obviously making sure that their prosthetic limb fits them correctly and is working adequately. If they need an aid, to use one, because that's one of the key things. People try to progress themselves too quickly, end up with an altered gait pattern, which obviously causes them kind of problems further up the chain. And then to get regular, for amputees, to get regular prosthetic appointments to kind of make sure that they kind of come in on a regular basis rather than leave it too late before things are out of control and they're having problems with their back and they're having problems with their limb and things like that as well. And try not to get into habits of try and walk as well as they feel they can rather than trying just to make do because they're going to get further problems down the line as well.
Great stuff.
That's great, thank you.